think so.
Yeah.
Yes. Thank you so much. I'm going to speak on oral semaglutide. Sunil has already spoken. He's a good friend of mine. I'm just going to pick it up from where he's left. Now we're going to talk about the various trials that have been there, and we're going to divide the whole meeting into three parts of it. It's a sponsored meeting, so that's my financial disclosure for the train for the same. I think in every era we live in something that has come that is new, and you've witnessed the same of it. There was Nehru era, there was Modi era, and I'm sure this is oral Rybelsus or oral semaglutide era. I think this is a revolutionary drug and with a revolutionary action, and it has been and a lot of data has come out. More than 5,700 people have been exposed, and a lot of data has come out. So I'm going to divide the trials into the 3A clinical program into few heads. So Pioneer 1 is with placebo, Pioneer 2 with SGLT2, Pioneer 3 with DPP4, Pioneer 4 with other GLP-1 receptor agonist, Pioneer 7 with a flexible dose adjustment versus DP4 with extension, Pioneer 8 with insulin, Indian 51 patients. Then we have Pioneer 5 renal impairment, Pioneer 6 CVOT, Pioneer Japanese trials of 9 and 10, and SOUL, which is ongoing to look at a superiority cardiovascular outcome trial. So basically, what I'm trying to say, it's been studied across all significant good drugs that has been there. We are not comparing it with to some feeble drugs, which is most of the trials I found that they do. It's been studied across. Sorry, yeah, it's been studied across good drugs, and that is where we're gonna see the evidence. I remember when I was in England, it was told to me कि भाई GLP at that time we had oral subcut exenatide, and the thought process many years ago was that more than duration of 5 years of diabetes GLP-1 will not work. So let's look at pioneer. What was the baseline characteristics of all people? So something which is common in all the pioneer studies, you will see that HbA1c was around 8% or more, and the duration of diabetes varied from 3.5 to 14 to 15 years across the various programs, and so did the age group. So it had a wider age group, right from 55 to 70 years that are there, and most of the patients who would wear BMI was more than 30 kilogram per meter square. So these were the baseline characteristics, fairly, as you can, rough guide that we can bring in all together. Now, whenever we do a study, it's always important to know what is the end point. What are you trying to find out from the study? So, Pioneer 1 to 5 and 8 has change in HbA1c as the primary point, and secondary point was change in body weight. Pioneer 6, as we know, was randomization and was an event driven trial, not a time duration trial. And it was time to first 3-point MACE, and secondary endpoint was time to first expanded composite CV endpoint. And Pioneer 7 was patients proportionate receiving target HbA1c less than 7%. Now, what is important or what is really nice to look at, it worked across all the pioneer trials with a baseline of around 8%. The HbA1c was reduction average was around 1.5% give and take in the various trials. Fairly remarkable reduction of HbA1c that has been there against powerful agents that we use. We are not talking about old, people will compare with old agents. Now, fresh off the market, it's like comparing, a new batsman has come and you're comparing him with Virat Kohli and Rohit Sharma, and then he's scoring better than that. That is what has come out of these trials. And we had 7 out of 10 patients hitting the target of HbA1c less than 7%, which is what our desirable outcome is of any molecule. And the post hoc analysis of patients, if you look at patients who had an HbA1c more than 9%, the reduction was up to 2.6%. Yes, all of us has put patients on oral Rybelsus, on oral semaglutide, and we shall all want to know what happens in our data with our patients. But with this post hoc analysis, it showed more than 2%. And it showed better time spent in glycemic control versus SGLT2, which is a very strong or very fairly useful product that we use on a daily practice that is there. Now, we all like to lose weight. Tell me, if I get diabetic, fingers crossed, I would like to use a medication which gives me all the benefits plus the bonus of weight loss. Who doesn't want to look nice? And across the global pioneer trials, it achieved a weight reduction of up to 5 kilograms. And the post hoc analysis, significantly more number of patients achieved weight loss greater than 5% as compared to placebo and comparators. Now, why more than 5%? When I was in England, there was nice guidelines on obesity and various guidelines across the world, and Sunil has attended the scope, and we have all attended online scope training. We know that 5% reduction carries a significant reduction of mortality and morbidity of the patients, and it minimizes a lot of risk factors. So that's a target to aim for most of our patients, that we like to do. Now when we are going to, cricket world cup and everything, we all want all rounders. We want somebody who will reduce the HbA1c, who will also cause weight loss, because at the end of the day we are greedy for our patients. We want the best thing for our patients. We want one thing that we can do everything. And the post hoc analysis, higher proportion of patients could achieve the dual target of reduction of HbA1c of greater than 1% and weight loss of more than 5%. And the odds ratio, as you can see, was significantly higher with oral semaglutide, trying to achieve the twin bowling and the batting of both HbA1c and the weight loss, because there's a fine balance that one needs to do. If we look at the Pioneer 6 trial, oral semaglutide achieved its primary endpoint with 21% non-significant risk reduction, which was there. The HbA1c and body weight decreased more in the oral arm as compared to the placebo arm, and there was more drugs used in the placebo arm as well. So people talk about Sustain 6 and Pioneer 6, but one must understand, you can't compare an apple with an orange. They were different trials looking at different things. One was event driven, one was time driven. And I think, yes, further data we shall know with the SOUL study, and furthermore data that is going to come out. Now let's dive a little bit deeper. As I told you about diabetes duration, and I think this is important because there is a thought process in mind. 5 saal, now I think it's gone on to 10 years or 15 years, GLP-1 or DP agents will not work. But what this has shown, that HbA1c lowering is independent of the duration of diabetes. It does not matter how long the patient had diabetes. It works in all the duration of diabetes that are there. Now, something which is very close to our hearts is our parents. I came back to India for my parents, and we want a molecule which is safe for our patients, because aging population is a different population profile as such, and we look after them. And what it has been shown, the reduction of HbA1c was generally larger across all age parameters that are there, that can be done. Now, if you look at HbA1c that was then on background medication, it irrespective of what the patient was medication, Pioneer 3, 4, 5, 7, and 8, we could see it was lowering independent of background medication. The p-value was significant. Even weight layering was independent of the background medication, the Pioneer 3, 4, 5, 7, and 8 that are there. Now, Asian population, we are a little blessed, as in placebo controlled trials of Pioneer 1, 4, and 8. Asians had a better HbA1 reduction as compared to other races. So, we have blessings, we have, God is with us in a lot of things in life. So, in summary, what we are looking at is if this molecule can be given in all patients, renal or hepatic impairment you can give, early therapy, middle therapy, late therapy, you can give in all therapies. It has got cardiovascular safety. Adverse effect is mild to moderate nausea and is consistent with the class of the molecule that are there. And the reduction of HbA1c is better and superior to gliptins and SGLT2, and the weight reduction is superior to sitagliptin, liraglutide, and empagliflozin. Now, what talks about gliptin and GLP-1? GLP-1s always are a more powerful agent, bada baba or badi goli, more stronger action than a DP4 against any day that is there for patient. Now, the question often asked in meeting, भाई किसको दे सकते हैं और किसको नहीं दे सकते हैं? So in the question that comes for oral semaglutide, the only question that I have in my mind, who I do not want to give this medication, or who otherwise I think you can give this medication to everybody on patients taking more than one or more oral antihypertensive second line agents, in where hypoglycemia is a concern, with established cardiovascular high risk, established renal hepatic dysfunction, older patients. Only type 1 diabetic patient, I would be very careful. I would not even give at this stage of to any patients oral semaglutide in patients who have type 1 diabetes. And I would be more careful to give patients who have got GI problems. So I think that would be the marker. GI problems definitely, and definitely, patients with type 1 diabetes, I'm not going to give. That is there. You see, if you look at the ADA data or ADA, we all talk about ADA standards of care or what they have said 2019, 2018, 2020. I don't believe guidance are for us clinicians, they're for nurses. But anyways, even if you look at the world was divided into before Christ and after Christ, with low cardiovascular risk and high cardiovascular risk. But the beauty of the drug of oral semaglutide, it fits in both places, that you can be given in patients at low risk and patients at high risk. And that is what is going to be a game changer, because there is no problems with renal function, even not though it's not recommended for end stage renal disease, but no restriction of oral semaglutide regardless of renal function that are there. So, in summary, we've got, and I'm sure all of us have put patients, and all of us are very eager. In fact, I have one patient who just called me this morning. He's been on 3 weeks now on oral Rybelsus plus an SGLT2 inhibitor. He's lost one belt size on his waist, and his sugar is better. And his daughter actually quoted him, said, "Baba, you are looking very handsome and you are looking very positive nowadays." I think that is what is the game changer is gonna be with this oral agents. So overall, if I say, it's a very effective medication, it's a safe medication, and more than that, it is a scientific breakthrough in innovation. I think I congratulate Novo for bringing innovation. I think it's one of the companies which brings innovation in diabetes care, and it has proven its worth when it comes to comparing with other agents, comparing with the duration of diabetes, and with a fantastic reduction of HbA1c. And we shall all look out for our own data, and maybe same time in the next conference of Sumirbratada, we'll be able to present real world data of Indian patients as to where we are with the data, with our own experience, and recommend people how to use it. Thank you so much, Sumirbratada, again for the opportunity. Thank you so much.
Thank you, Mithun, for being a T20 player and completing your session 5 minutes ahead of time. We have both the speakers have done an excellent job. And
taking Rybelsus properly is important for adequate absorption. It must be taken on an empty stomach with a sip of plain water. Rybelsus is co-formulated with an absorption enhancer that works to locally buffer the acidic pH of the stomach and increase transcellular absorption. Waiting less than 30 minutes or taking with food, beverages, or other oral medications will lessen the effect of Rybelsus by decreasing its absorption. Waiting more than 30 minutes to eat may increase the absorption of Rybelsus.